Good morning, everyone. Welcome to today's web seminar, Lessons from CalYouth, Young People's Physical and Mental Health. We're delighted to have today's web seminar to really delve even deeper into the wonderful study that is led by Mark Courtney at Chapin Hall at the University of Chicago. But before we delve into the findings, we're just going to take a moment to make sure everyone has the information necessary to participate. So the slide that you see now has the call-in information and the access code. We want to make sure everyone knows that today's web seminar is being recorded and that the presentation materials will be posted, both the slides as well as the slides and audio, and that will be at the CaliforniaFosteringConnections.org website. That is the website where we archive all materials related to extended foster care. We do invite you to submit your questions as you have them. I'll be collecting them, culling through them, and also submit your comments. And I will commit to kind of reading them to further enrich and inform the conversation, because we have a really wonderful mix today of everything from probation officers, social workers, administrators, nonprofit housing providers, CASAs, really a whole range of stakeholders, researchers, and the more input we have and the more points of view we can share, it can be a much more interactive and interesting conversation. So what we're going to do today is the third of a three-part series on the CalYouth study. This, I mean, dare I say, it's not superfluous, groundbreaking study has been so important for us in California. When foster care was extended, the commitment was to improve the quality of life for the young people who participate in extended foster care. Are we making a measurable difference in the lives of young people in terms of their education, health, housing? And thanks to this study, we actually can answer some of these questions. This is the third of a three-part study. The first one was on housing. Very interesting. Lots of important findings to improve both our practice and our policy. The second was on education, both K-12 and post-secondary. And then today we get a focus on physical and mental health. So if you weren't able to participate in the first two, we really encourage you to go back and listen to them, particularly at this time of the year. Those of us who are advocates, who are thinking and developing agendas for next year and asking ourselves, where can scarce public resources be invested most wisely? Where do they need to be invested? Where is the highest need? And again, thanks to this study, we actually have answers and we can draw on evidence to support those policies. So to inform us today, once again, we have Mark Courtney at the University of Chicago. So we want to just take a moment. This is our third and final web seminar on this study to just sincerely thank Professor Courtney for taking the time. He does the research along with his team, but these web seminars, require a certain amount of time and attention, and really going the next step to push this information out into the field is above and beyond. So we want to thank Professor Courtney for all of his research and the time to share it with us today and in the previous presentations. We're also going to hear from Lori Cappy of IE Communications, a very close collaborator on the study. And Lori's going to tell us about CalYouth in the Loop. And then after Professor Courtney presents his findings, we're going to have a discussion led by Anna Johnson of the National Center for Youth Law about what are some of the policy implications. What direction does this point us in? After we hear this information, what should we start to think about in terms of the future of policy around physical and mental health? And so with that, I'm going to turn it over to Lori Cappy to talk a little bit about the project and CalYouth in the Loop. Thank you, Lori, for being here.
Thank you, Amy. So on the slide that you can see, I'm not going to read it, but I just wanted to acknowledge on behalf of myself as well as Mark, the funders and partners in the CalYouth study. So as you can see on the right, we have both public and private support for this multi-year, multifaceted study. Those are listed on the right, starting with the California Department of Social Services and including, as you can see, many private funders. And the role of these funders and partners are to both support the research, also very much engaged in providing guidance and feedback as the study has gone through various stages and phases. We also have a CalYouth Study section with results and downloadable short form of the results on the website of coinvest.org. And as we're doing today, part of our role is to promote via presentations and media outreach the results of this study so that it doesn't sit on a shelf, but that, as Amy said, it's actively used to promote policy and practice reform. So if you could go to the next slide for me, Amy. So here is just a screenshot for you of the California Child Welfare Co-Investment Partnership website, and where you can see the video clips from the Fostering Futures presentation, day-long presentation on many of the results that we're going to just hear a summary of today. Could you go to the next slide, please, Amy? But a related project, a very important related project that I want to do a quick pitch for is called CalYouth in the Loop. And as many of you know, we now have approximately 9,000 non-minor dependents in California that have opted into extended foster care. And our goal is to take the results of this study and, wherever possible, get feedback from a subset of those non-minor dependents. Particularly this year, we're looking to hear from the 19-year-olds, which reflect the study sample that Mark is going to be talking about shortly. And the ways that youth can do that is they can go to the website we have called CalYouthintheLoop.org, and we're taking various approaches to engaging youth, including, and if you could go to the next slide, shows how youth can, and many of you, I don't know how many hundreds of you are on the call, but I imagine a subset of you are in direct contact with youth that have gone into extended foster care, or perhaps some youth who have not, but were in foster care and are now 19. So we have two pathways for them to respond to a small subset of questions where we can get their feedback on what these results mean. So if you could go to the next slide, please, Amy. And part of the approach we're taking is to really honor the youth and what they can provide. So we are basically compensating youth prospective recruiters. So if you know of youth that might want to learn some skills, reach out to their peers. We will also stipend them, as it lists here. And since we started this program, I have to say we've had a really, really good response, but we would like more. So please encourage youth that you may know or to get involved in this aspect of the study, which, as Amy alluded to, will really inform policy and practice going forward. And I think that's it for me.
Thank you very much, Lori. Let's turn it over to Mark.
Okay, thanks. So what is CalYouth? Before I start sharing some of the findings today with respect to health and mental health, I should let you know what CalYouth is. Now, Lori's provided a lot of background. Let me just describe the nuts and bolts of the actual study. The study includes, we're following young people, basically we're following young people who are on the verge of aging out of care in California or would have aged out of care in the past into young adulthood. And there's three kinds of data that we're using to reflect on their experiences and what they need and how they're doing. One is a longitudinal study of a group of young people who we're interviewing at 3 points in time, and I'll describe that in a minute. Secondly, we're doing periodic surveys of caseworkers serving young people in California foster care, and we've done that we did that back in 2013 for a group of young people who had just turned 18, and then we did it last year for the young people in our study who were still in care at 19. And we're also analyzing government program administrative data through our partnership, through the co-investment partnership. California Department of Social Services has been very helpful at getting us information on things like whether young people are using public assistance programs like CalFresh or CalWorks, whether young people are employed, and things like that. So next slide. So let's talk about the Longitudinal Youth Study. So the Longitudinal Youth Study that involves us actually talking to young people covers a wide range of those young people's experiences. We really want to get at everything a responsible parent would want to know about their child, really. And of course, for these young people, we want to know about their experiences in foster care and services and their perception of those services. But we also want to know about just how they're doing in terms of employment, health, development. We collect a lot of data on their social support, their behavior, whether they're having children or not, their relationships, intimate relationships. And so I encourage everybody on the line, if you're interested in things other than health and mental health, you'd find a lot, I think, in our reports. And as Lori said, they're easily available at the Co-Investment Partnership website. Next slide. So with respect to the youth surveys, when we started the project, we intended to start with a group of young people at age 17 and then interview them 3 times, at age 17, at age 19, at age 21. And these are young people who were approximately age 17. They ranged from 16 3/4 to 17 3/4 back in 2013. So they were in a position to move into extended foster care after the law had been in effect for a couple of years. And they had all been in care for at least 6 months at a time. So these are folks who, had been in care for a while. We've interviewed them twice now. We interviewed 95% of them back in 2013 when they were 17 years old, and then we were able to follow up with about 84% of that original group when they were 19 years old last year, and that's really what I'm going to be sharing with you today, what they have to tell us about their health. So next slide. This just gives you a sense of who these young people are. A bit more than half of them are female. That reflects the population of young people transitioning to adulthood out of care in California. As you can see, almost everybody we interviewed at the second time was 19. There were a handful who had had their 20th birthday. Almost half of these young people describe themselves as Hispanic, and you can see that it's also a racially diverse group, and that about 1 out of 10 another language other than English is spoken at home. So, it reflects the diversity of California and the diversity of the foster care population in California. Next slide. So this is kind of important information to have as I describe these health status outcomes, because in some cases they vary, or at least the services that the young people are receiving vary between those who have left care by age 19 and those who remain in care at age 19. So that's really the purpose of CalYouth, is to understand how extended care is working. And one of the things is how many people are taking advantage or are able to take advantage of extended care. And you can see if you look at the left side of this graphic and you add up the in care and ones that never left. So in other words, we interviewed them at 17 and they never left care. That's almost 2/3 of the young people we talked to at 17 had never left care and remained in care at age 19. Another 13% had left care at some point but re-entered care, which is one of the provisions of the law in California that makes a lot of sense to me, and I think lots of observers. So between the two groups, you can see that about 3/4 of young people in California at age 17, who've been there for at least a few months, are still going to be in care at 19. But about 1/4 of them have left. And you can see that if you look at the right, about half of those who had left before the age of 18. Next slide. So now we'll get into how's their health. And we wanted to start with just a general health rating question that gets asked in all kinds of surveys. How would you characterize your health? Excellent, good, or very good, good, fair, or poor. And generally, anybody who characterizes their health as really anything less than excellent or good, is maybe has some issues, particularly those who characterize themselves as fair or poor. And you can see that about 28%, 24% rated their health as excellent, and 58% good or very good. But it's almost 20% that rate themselves as fair or poor. And if you look at the right side of that graphic, what we have there is the same ratings from other 19-year-olds in the general population from the National Study of Adolescent Health. And you can see that young people in the general population are much less likely than these foster youth to characterize their health as fair or poor. So that speaks to just the perception of a significant percentage of young people, 19-year-olds, many of them in care, some have left care, that their health is not ideal. One other thing I want to emphasize here, it's not shown in the graphic, is one of the health problems that we observe among young people aged out of foster care that is higher in that population, significantly higher than the general population, is obesity, which is a problem in the general population, but we also see it as a problem here. So at baseline, at 17, about 19% of the young people we interviewed would be categorized with a body mass index that categorized them as obese. That was 22% at wave 2. Now, that's not a big difference, but we're not seeing any decrease in this major health problem, obesity, among this population. It affects about 1 in 5 young people transitioning to adulthood out of care. Next slide. With respect to behavioral health, we capture lots of information about behavioral health in the study. So this is, again, based on responses by these young people. And you can see that about 20% of them reported thinking about suicide since the first time we talked to them, and 7% had attempted suicide during that approximately 2-year period. Now, those numbers are certainly troubling, but they're actually significantly lower than what we observed when we talked to young people at 17. So at least the trend in suicidal ideation and suicidal behavior is actually in the right direction over this 2-year period of time. We see that about 1 in 10 of these young people answered the questions in our survey in a way that would categorize them as suffering from a depression, much lower percentage mania, post-traumatic stress disorder, and the total percentage that reported at least one mental health disorder, we show a few there, was about 27%. And we also asked the young people questions that provide us with a diagnosis of alcohol dependence or abuse or substance dependence or abuse. And you can see just around 1 in 10 of the young people answered the question in such a way that we have characterized them as suffering from alcohol dependence or abuse or substance dependence or abuse, respectively. But a total of 14% of young people, there's some overlap, some of the young people are abusing substances and drugs and alcohol. 14% of them exhibit one or more substance use disorders. And then if you add substance use and mental health disorders together, you get about 1/3 of these young people meeting the diagnostic criteria that we asked about for a substance use or mental health disorder. One other thing that we collected data on is smoking. And we found that 27% of young people reported ever smoking during the past month, and that 24%, so basically among smokers, virtually all of them smoked at least 1 cigarette every day. So about 1/4 of these young people are regular smokers, which is a public health problem we also want to pay attention to. Next slide. So this slide gets at services. So, clearly there's a lot of these young people who have needs for health and mental health care. And what I want to start with is insurance. So the good news here is the overwhelming majority of young people Actually, I think you have to push the button again, Amy, to show the insurance stuff. I'm talking about it first here. There we go. Thanks. Whoop, go back. There we go. Overwhelming majority of the young people have health insurance, 93%, 82% have dental insurance. But there was a significant difference, statistically significant difference between the young people who stayed in care and those out of care with respect to insurance. So 95% of those who stayed in care report having health insurance. And truth be told, the other 5% need to be educated that they have access to health insurance. But 95% of them realize that they do. And then 84% of those who had left care had health insurance. We see a similar difference with dental insurance, where 85% of the young people in care report dental insurance, but only 69% of those out of care. And this health care for both groups is overwhelmingly provided by Medicaid. So that's very important. 95% of the young people in care report that the health insurance they have is Medicaid, and 87% of those out of care. So even those out of care, if you do the math there, it's almost 70% of the young people out of care are relying on Medicaid for their health care. And that's important because, that first of all, it means Medicaid is a major resource for these young people, but it also has implications if the change in government at the federal level results in any changes in the Medicaid program. It clearly could affect this population. The overwhelming majority of young people in care report having a physical exam within the last year. But if you look, basically most of them had a physical exam within the last year, and then you can see that around 25% say, well, it was more than a year ago, 1 to 2 years ago, and then relatively few, greater than 2 years ago. And the pattern looks pretty similar for dental care. But we see some differences by care status. Basically, young people who are in care were more likely than the young people out of care to report having been seen in the last year. So, this access issue that we're seeing with respect to health insurance also appears to be playing itself out in terms of accessing health care. 18% of the young people overall reported that they were unable to receive medical care at some point, and 13% they were unable to receive needed dental care. And the main reasons they said they weren't able to receive medical care is not having insurance, not knowing where to go, and a lack of transportation. So we do have some access issues in terms of these young people being able to access health care, particularly for those who have left care. Next slide. So now we get into mental health services in particular. So you can see that 27% of the young people reported receiving counseling in the last year. That's a significant decrease from baseline. And while we do see, we have to piece this together, and we're working on an issue brief on this. So those of you interested in mental health services, stay tuned. Should have that out early in the next year. But there's a big decline from 54% of the young people at baseline at 17 saying I'm receiving counseling to a little over a quarter, 27%. There is also, though, a decline in the prevalence of mental health problems from wave 1 to wave 2. So that's probably driven to some extent by that, but it could also be driven by access issues. And I know that we're going to hear some discussion about that, the shift from the mental health system that serves minors and children to the mental health system serving adults can result in a discontinuity of mental health services. There's lots of evidence of that, lots of research on that. So we'd be a big shift there. You can see from the graphic there that 15% of these young people report receiving psychotropic medications in the last year. That's a decline from 29% at age 17. So basically you see a parallel reduction in both counseling and psych meds utilization. The rate of utilization of those services declines by half between 17 and 19. One of the things I want to mention around psychotropic medication utilization, we ask a series of questions in our report. So those interested, I really encourage you to look at the report, the section on health and mental health, because we've got a series of questions about, of the young people who receive psych meds, what were their experiences of that. And the question I want to share with you is we have a question that says, basically, the benefits of these drugs outweigh the negative effects. We ask about side effects. And so that's worded positively, basically. But what we see is that 1/4 of young people at age 19 who were receiving psychotropic meds disagreed with that statement. So in other words, they believe that the negative effects of their medications outweigh the positive effects. Now, the good news there is 3/4 of them feel otherwise. But nevertheless, we have 1/4 at age 17 or at age 19. And age 17 is a similar percentage. About 30% said, you know what, the benefits of this are really outweighed by the negative side effects. So psychotropic meds are still something we definitely want to keep our eye on. Much lower percentage receive substance abuse treatment, about 6%, and about 9% report having ever been hospitalized for a mental health problem. There is a difference in care status, though. We don't see any difference in psychotropic meds, but we do see that young people who have left care were more likely to receive substance abuse treatment than those who remained in care. That's probably a function of the fact that young people who left care were a bit more likely than those in care to report a substance abuse problem. So that substance abuse may have a role in whether young people remain in care or not, either because they choose not to or because their substance abuse gets them in situations where they're deemed really ineligible in some way to stay in care. Next slide. Okay, so I want to add this. It's, we quite often don't think about these things as health issues, but the Center for Disease Control certainly does, and I certainly do. So victimization is something that we look at in the study, and you can see that it's not a huge percentage, but non-trivial percentage of young people report that someone, they saw someone being shot or stabbed. So, I live in Chicago, and, we've got a lot of that going on here. Basically, people being traumatized by witnessing violence. I know that happens in California as well. And you can see here that a significant percentage of young people are reporting seeing violence or actually having, being victimized themselves. So, and right here we don't show the overall numbers, but we show a very important distinction. That is, it looks generally like the young people who have left care are being exposed to more violence and victimization than the young people who are in care. So the figures that are in the sort of salmon color there indicate statistically significant differences between the young people in care and those out of care. So 13% of young people who had left care reported having someone pulling a gun on them, compared to about half as many young people who are in care. And similarly, 6.3% of the young people who are not in care had somebody basically beat them up and steal something from them, and about 1/3 as many young people in care had that happen. So even though the numbers of young people in care who are experiencing victimization is troubling, the percentage of young people who have left care, I think, is really troubling in terms of the ones experiencing victimization. So I think that's it.
Thank you, Mark. Now we're going to turn it over to Anna, who's going to talk through some of the policy implications. We've gotten a lot of very good questions, and so we'll hear from Anna, and then we'll turn it over and pose those questions to both Mark and Anna. So thank you, Anna, for being on today's web seminar.
Yes, thank you, Mark and Amy. Good morning, everyone. Today, I'm going to speak a little bit about what we've heard from youth on the ground, from providers of physical and mental health, from advocacy agencies, from just the people that are working with youth as they transition in and out of care and as they age into adulthood. Some of the things that we have seen here in California related to physical and mental health is that there's a fragmented service system. We have different service deliveries for the medical and mental health, and then even at the county level, divisions between the managed care and county mental health care services. We have differences seen in the children's system and the adult system. There's even differences in insurance, which can be if you're in Medi-Cal And if you are an SSI and you're also in Medicare, you're called Medi-Medi, and that might also have some issues about who are your providers and who you can go see. So even further fragmentation. And then when you're thinking about youth who are transitioning in and out of care, they could be moving counties where they were in care and now they might not be in that county. And then again, you've got another fragmentation at the service system level. So we know that there's these various struggles if you're a 19-year-old thinking about your mental health, your medical and physical health. How are you going to navigate these systems? It's not easy. It's very complex. The second point here, just the landscape on the ground, is that foster youth historically have had inaccurate and incomplete health records. Many of these records don't contain the medications that they've been on. They don't contain the vaccines that they have or have not had. This has different implications when you're moving from the children's system of care to the adult system of care and maybe going to new and different providers. A lot of the providers say, where's the warm handoff? Where is the discharge information? How is our system helping youth bring those accurate materials to their new providers? What we've seen is that it's really not always happening. We've seen youth that have said, well, I'm going to a new doctor, but I don't have my records. I don't have my health records. I want to set up an appointment, but, I want them to know what, everything that I've been through, everything my body has been through. And we've tried to help youth call and get their records. It can take 6, 7, 8, 9 months to get that back from the county, oftentimes when you have to black certain things on the record out. You've got to go through some court paperwork. So those barriers can delay health services and really complete health services for our youth. As Mark mentioned earlier with insurance, we have a lot of youth that are enrolled in their plans, but at every age as they're getting older, the services that are covered change. And a big question we have is who's helping youth both set up savings for medical and mental health care services that they're now going to be paying out of pocket for if they want to continue, if they're not covered anymore. Certain dental or optical care is not necessarily going to be covered as you go older up through age 26 with the Medi-Cal extended to 26. And youth don't always know that what they're going to get at this age is going to change after their birthday, that they're going to have to pay for that, and where is the health savings there. The final point on this page here is about access to quality and culturally appropriate services. Here in California, about a little over 70% of our youth in care are youth of color, and that doesn't necessarily match up with our mental and medical service delivery system. The other thing that we've heard is that youth really want informal and formal mental health supports and medical, physical health supports. They want to be connected to a gym, to a sports team, to a dance troupe, to art lessons. They want to be connected to other healing services that can help maintain and manage their physical and mental health, in addition to having the access to formal mental health services. And as you're exiting care and maybe changing where you're living, maybe moving to a new community, how are their transition plans and supports to get you connected to those physical and mental health services and community systems that are going to help you maintain that level of health that you need. Finally, the substance use services. We know that there are oftentimes not, it's hard to find them. It's hard to access them. It's hard to give up that much time that it takes to complete these services, especially when you're trying to hold down housing or hold down school. And so the way that these services are delivered are not exactly set up for what youth need as a holistic part of their life. And they're just really hard to find, is what you say. Thank you, Amy. Next slide. So just a little more from what we've heard from youth and from the study. So in the study, hospitalizations we see for pregnancy a lot, for illness, injury, or drug use or emotional problems. So pregnancy was sort of the #1 reason why youth are being hospitalized. And this goes back to, where is this warm handoff? Does the youth have a clear, that's my doctor? Do they know their doctor's name? Do they know their provider system? Have they had information around reproductive health and access to those services, so that we're not, going to a hospital for what would be routine women's health care? Really trying to move towards establishing a clear health home in the mind of this young person, where they know they go to that person. Some of the policy implication there is that the independent living programs and transition plans, a lot of you say, well, we really started that when I was 17. We really started that too late. We only got through half of the things on our transition plan, or, and if you look at the study, the CalYouth study, it says in the study that youth are not feeling well prepared to manage their physical health and mental well-being. I think it was about 30% of youth said they got a lot of preparation to deal with that, which means about 70% of youth did not feel well prepared to be the manager of their own bodies. So we really need to focus on skills development and empowerment for our youth within this existing structure in California. Again, pointing back to community supports and connections, youth have reiterated over and over again that they want to be connected to mentors, that they want a support system. And when you leave care, you had this formal support system of a social worker, judge, dependency attorney. Those people were your people, and as you age out, they're not there anymore. So who replaces that? And how are we setting up youth in the communities that they live in now? And it just takes time to find new places for physical and mental health. It takes time to choose your provider. And a lot of times youth, if they don't have support in that, I know this was true for me when I was younger, that you just wait until crisis and then you get who's available at that time rather than being proactive. Finally, as Mark mentioned earlier, and a lot of the work that I've done is around psychotropic medication use with youth in foster care. The two really important things as youth are aging out and becoming the consenters, the true consenters of their own mental health treatment, and being able to more firmly say yes and no to medication, is that they need information and resources about how to manage the short and long-term effects of medications, the physical health side effects that often come along with these medications, such as obesity, tics, tremors, heart disease. These are lifelong disease management things that you have to work on, and a lot of times youth have mentioned, I've had a really hard time gaining weight or losing the weight that I gained on medications. I feel really good now about the medication I'm on because I talk to my doctor and say, I need a lower dose, this is too much, I'm sleeping through class, or I can't move my legs and get up for work at the right time, and they're better able to advocate for themselves, but still there is still a need to manage those side effects and know how to do that and navigate that system. And then again, a lot of youth, as you know, are what we see in the study is that there's a decrease in the number of youth on psychotropic medications. Now, in some cases, that's youth have been going cold turkey, or youth have not been able to access medications, and they've had an interruption or a lapse in care. And there are further physical health risks with that associated with going off medications unsafely. And so as kids are exiting, as youth are exiting into adulthood, we really need more information about how to come off safely and to support those youth. So I'll just wrap up with my final slide here. Here are sort of the things that we're looking to improve about this fragmented service system and in regards to empowering youth and providers as they're aging to navigate this new system. So again, thorough transition planning for physical and mental health, connecting youth to the adult system of care and the range of services they need, but doing this before they leave the system so that they know a little bit more, can ask questions, and can have help. Ensuring youth have access to their complete medical and mental health records. This needs to be done for many reasons about managing your own health care, and right now waiting 6, 7, 8 months to get it from the courts is, that puts us back. Linking youth to providers, especially here with reproductive health. We know this is a need, especially when 13% of the hospitalizations were for pregnancy. We need youth to have their health homes set up sooner. With regards to who our youth in care are, developing the local network of available providers for substance use and mental health services who can provide culturally appropriately and linguistically appropriate services is really important to our youth. They want providers that look like them, that understand their belief systems, that will respect those belief systems, and they want a choice. And that's not been a reality for many yet, but it can be. And finally, just improving coordination between the service systems. We've got physical, mental health, managed care. Everybody's got their own electronic health records. Everyone has their own way of operating. And there needs to be clear connections and communications, both at the local level, but also at the state level with the guidance that's going down to the counties and the service providers for how to work with young people transitioning into adulthood, and to really educate our providers about the needs of this population and how to really be their anchor for health. Thank you.
Thank you very much, Anna, for teeing up, how this really plays out, and how we can focus our thinking about what direction these findings point us in as we move forward in policy and practice. There have been a lot of great questions, and so we'll get through as many as possible. The first one is for you, Mark. I'm not sure you'll have a answer for this, but I think the person who poses it would like to hear your comments. The question is the 3% PTSD figure on your slide about behavioral health doesn't seem to make sense in view of the significant trauma exposures that these young people have experienced. Could you comment on that, and did that surprise you? Anything you can say about that?
Yeah, so PTSD, I would say the prevalence rate surprised me a little bit, although you can look at another study I've done, the Midwest Evaluation of Adult Functioning Former Foster Youth, and the rates are higher than that, but they're not as high as some of the other reports that are out there on PTSD among former foster youth are. So I think that anytime you try to assess PTSD, you're challenged with, how many kinds of trauma you ask about. Now, we certainly ask about, this kind of trauma, and young people aging out of care are aware of it. But so I guess this is a long-winded way of saying one thing might be the way we measure it, but it also may be this, the symptoms that young people have. So the way you assess PTSD is you ask, first of all, have you had the following kinds of traumas, and generally a fairly long list of those. And then you ask about symptoms that they have, and a lot of that's reliving the trauma and the consequences of reliving the trauma. And so we saw a higher rate of PTSD at 17, I don't remember off the top of my head, but certainly a lot higher than that than we see now. And it may be that, and to some extent, this is a function of young people either getting older and not suffering those symptoms as much, and or being treated through the system. So that's all I can really say. Is part of it may be that we're missing some PTSD with the particular measure we're using, although it's a measure used by lots of people who are assessing mental health problems, not just in a research context, but in a clinical context. But that's possible. And then the other one is that, in fact, the symptoms have declined between 17 and 19.
Well, and to follow up on that, on your slide on behavioral health, across almost every diagnosis, they were reduced from age 17. Is this something that happens in the general population? Do we get a little mentally healthier as we get older?
Yes and no. So I think that some, particularly psychosis, which we have a separate assessment of psychotic symptoms, and that stays pretty high, actually. And there's a lot of psychoses where onset begins in early adulthood. But for some of these other problems, there's a significant decline, and particularly externalizing problems. We know that chronic disorders, those kinds of things, decline from late adolescence to early adulthood. So it depends on the nature of the problem. But yeah, we see declines. We're getting ready to publish again an issue brief on mental health, so it'll be clear, and I haven't shared that yet with our partners yet, but just looking at the Wave 1 report and Wave 2 report, you see declines in a lot of these major categories of mental health problems, but not so much psychoses.
Okay. This next question is for you, Anna. What do you mean by informal mental health? What is that?
Sure, and I think that informal mental health, what that means to young people, are the services that help them maintain and manage their mental health. Things like physical activities, art, dance, music, those types of therapies, or just as part of their daily life. Being able to go for a walk is often new for youth who might have been living in group home settings earlier in their life, but now as they're an adult and have a little more freedom, they have access to some of these more informal types of support. Being able to go to a yoga or meditation, a new service that they might not have had access to earlier, things that just help manage that and build the coping skills for when you are having a stressful day, when you are having a difficult time. Learning about those kind of things are really important to young people. And I think it pairs with the question about trauma and how do you, when you have had developed these behaviors that protected you in one environment, in one part of your life, that may not apply anymore as you're aging, as you're an adult, and as you have more freedom around where you're living in your environment. What does that really mean to you, and where can you go for support?
Okay, thank you. This is kind of a question and a comment. I think it's a really good one. Says, I have a question. How does the fact that 1 in 3 youth in extended foster care, the fact that 1 in 3 have a mental health disorder, mesh with our current requirements to be working or in school to stay in extended foster care? I think there's kind of a comment in that, we do know there are participation conditions, and there is the 5th condition, which if you are unable to do one of the following, one of the above, you can still participate. But I think the person makes a very good comment that it does look like, over 1 in 3 have a mental health disorder. Now, Mark, can you help us you're using kind of standardized diagnostic tools. This isn't a young person saying, oh yeah, I had a manic episode. If I do recall from the methodology, you have a standard set of instruments that you use, so that these are hardcore, these are real diagnoses. Is that correct?
Yes, they are. And one thing I should say, this is a good way to go back to that last question. In the report, if you read the methodology, sometimes young people say, I don't know, they refuse to answer questions. Mainly, I don't know, you ask about a question. And these diagnoses are based entirely on where we got answers to all these diagnostic questions. So something like depression, we will ask, if you had a period where you were down, there's a set of diagnostic criteria, behaviors, the diagnostic and statistical manual, that mental health professionals use to diagnose people and to get paid, for treating mental health problems, is based on a set of behaviors and experiences that you have a certain number of those over a period of time, then you meet the diagnosis. And so yes, the numbers I'm giving you are for positive diagnoses, and we do have cases where we can't make a positive diagnosis for sure because they didn't answer all the questions. And in some cases, if you add those percentages, the numbers go up. With respect to the question around meeting the eligibility criteria, the law nationally says, if you have a medical condition, and that's been defined very broadly by the Obama administration and in California. So I would say that a young person, if they have, the way I prefer to think of it is a functional limitation, whether that's physical, or emotional, that would get in the way of them working and going to school, then they should be eligible under that category, and then it behooves the folks in the system, quote unquote, to help them deal with that functional limitation.
Thank you. Another question, this is more of a process question, but the questioner asks, we know the Midwest study went to age 23 and 26. Do you sense that the CalYOUTH study will be able to look and determine whether these positive effects of being in care are sustained after young people are out of care? Do you expect that the study will be able to go out that far?
Right. So hope and expect are two different things. So with our partnership with the state, I'm quite optimistic that some outcomes like employment, going to college, using public aid programs like CalWORKS or CalFresh, that we'll be able to look after the age of 21. These kinds of outcomes are much more difficult to track. In fact, some of them you can't track at all, really, without interview data. And we are not funded presently to do interviews after the age of 21. In the next year, we'll begin conversations with our partners in the state and then potentially other funders if there's interest in trying to follow these young people past 21. I think it makes a whole lot of sense to do that because, you'd like to see that the benefits of care that we perceive so far, we have to be cautious there, we're continuing to study that, but so far so good. You'd want to see that they don't, disappear at the age of 21, and we didn't see that in the Midwest study, but California is a new place to be asking these questions. So I hope to do that. I'm very optimistic that we'll be able to do that with some of the outcomes because it just doesn't cost that much to use administrative data. But to do another wave of interviews, is fairly costly, and we hope to raise the money, but we don't have it yet.
All right, just a few more questions and then we'll wrap up. One question is from earlier in your presentation, Mark, you said that 34% remain effectively and a quarter leave. Is that consistent or is it comparable to the other states where you have conducted research? How do we compare to those jurisdictions generally?
This is in terms of the percentages of young people who are remaining in care, you mean?
Yes.
Yeah, so I would say California looks a lot like Illinois. So the only study that I've been involved in that looked at this in great detail was in the state of Illinois, and about, not quite 4/5, around 3/4 of young people we started with at roughly the same age, about 17, 17 and a half, in Illinois were still in care on their 19th birthday. And about half of them were still in care on their 21st birthday. Now, it's too early to say whether that will play out as well in California. You could look at some administrative data. But, yeah, these numbers look a lot like another state that had had a policy for a long time of extended care and a fairly inclusive policy. Interestingly, Illinois did not have a reentry policy. And so even without a reentry policy, their percentage of young people remaining in care looks a lot like California. That's interesting. If California didn't have a reentry policy, it's hard to know whether those young people who left and came back would have left in the first place. But presumably some of them would have. There are other states. I do know this from just looking at the data that you can get on the federal website, the Adoption Foster Care Analysis and Reporting System, that there are states that have quote-unquote extended foster care that have much lower uptake rates, if you like, than California and Illinois do. So I would say California is on the higher end of the percentage of young people who are staying in care, but it reflects the relatively inclusive policy in California.
Well, this next question is similar to a conversation we've had before, Mark, around, from your study, just as you go through every criteria, young people who stay in care are faring better. And it's often, if not always, statistically significant. So the question is, are the young people who are remaining in care somehow on a fundamental level different than the ones who are exiting? And what do you know about that, and what will you know about that? Because obviously if they are constitutionally different in some way, either their mental health status or something else, then that makes it harder to conclude that, you know, foster care is a protective factor. Can you help us understand that so that we can know whether we should be happy or maybe skeptical?
Right. So, yeah. So, one thing I would say is stay tuned. So, you know, I can't share a lot of details of that, but I can say the following. We are looking at two things right now, and these will be briefs that, again, reports will come out from the project early next year. One of them is looking at what are the predictors of young people remaining in foster care or not. And what we see is, and we did analysis like this in the Midwest study as well. Clark Peters, who worked with me on that project, has looked at that in Illinois. Individual youth characteristics, some of them are associated with, you know, who stays in care and who doesn't stay in care. But so for example, young people with substance abuse problems at baseline are slightly more likely to leave care than those who don't have substance abuse problems. But some of the things that we see that are predictive work in the other way. So they have to do with young people who have a lot going for them and just decide, you know, so you can imagine a young person who gets a scholarship to go to an elite university and has everything paid for, maybe they even went out of state, they don't want to be bothered, right? So they're not in care. So there are characteristics of young people associated at the, you know, individual level, but they're not really strong predictors, actually. County is a pretty strong, you know, county is associated with it, as well as, you know, youth characteristics. So first of all, we don't have evidence that only high flyers are staying in care and only young people who have lots of challenges are leaving care. But we're looking at that, and we're gonna publish a report that gets at that. The other issue, which relates to, well, the other issue is that we are looking right now at outcomes controlling for the baseline characteristics of young people. And, you know, that isn't public yet, but I would say there's nothing there that makes me feel like, you know, there aren't benefits of extended care. But it's complicated. I think some of the things that you see in the report, differences between those in care and those out of care, go away when you control for those characteristics. Most of them do not.
Well, I'm going to choose from that to say we should be happy about it.
Yeah, I think so. I think that don't let what I'm saying make anybody feel like it's going to be some horrible, you know.
Well, and anyone knows that these programs, I mean, we want the evidence, and so many people on the web seminar, you know, see the difference it makes, and so it's very exciting, and it's why the report's so important. Maybe one last question. It was stated that ILP services were incomplete for many youth exiting foster care. Were youth asked if they received reproductive and sexual health education in a manner that benefited them? And Mark, if you could maybe start by answering this, if you can recall, kind of what was the pregnancy rate at 17 and 19? I know that we draw on that data heavily, but was there any information about the specific receipt of these kind of reproductive and sexual health resources to young people?
Yes. So I don't know off the top of my head. I think it's about a third of the young women have had a child by the age of 19, if I recall correctly. It's about right. It was less than that at baseline. I think it was about half that. I'm looking right now. We asked a question of satisfaction of life skills preparation, and the scale goes from 1 to 5, with 5 being the highest rate of satisfaction. And we asked a question about family planning, and it's about 3.4. And that's actually on the upper end of satisfaction. So financial literacy, 3.1, housing, 3.1, education. So they seem relatively satisfied with the family planning services they got, and parenting preparation. We asked the parents, were you satisfied with the help you got there? Again, about 3.5. I mean, you know, I get teaching evaluations. I like something above 4 myself on a 5-point scale. But, you know, 3.5 is not bad.
Okay. Well, I just want to take a moment to, again, thank you very much for this wonderful research and for taking the time to be on these web seminars. They are recorded, and they'll be on the website. Thank you, Anna, for bringing the implications of this study to mind in California as we all continue to, you know, advocate for better practice and better policy. And thank you, Lori, for telling us about the co-investment partnership and CalYouth in the Loop. And so with that, that does conclude today's web seminar. Thank you all for being on it, and have a great day. Take care. Bye.
Bye-bye.